Well, thank you, Sherry, and thank you, audience. It's a real privilege to be back here. I feel as though my heart really is here at Englewood Hospital and Medical Center. Um, as you can imagine, I first developed my interest in patient blood management when I was here, and the program was just beginning back in the early 90s. I like to think that I carried some of what I learned here and expanded upon it in my current site at Beth Israel Medical Center in New York. I note that I'm not the only Friedman on the schedule on the program, but I also note that I am the only obstetrician on the program. I can only tell you that in terms of patient blood management, I think about everything that needs to be said about it has already been said. But I do have the benefit that everyone in medicine is afraid of women and the menstrual cycle, so I get the chance to say it all about women, hopefully using slightly different words. What I want to do today is talk about sort of a potpourri. I want to talk about three areas that I think present special issues in patient blood management, specifically for women. Okay, which of these devices? Did that do it? Okay, so the three areas that I would like to talk about this afternoon are iron deficiency anemia, which you've already heard is an under-addressed issue, obstetric hemorrhage and some of the new developments in the management of obstetric hemorrhage, and perimenopausal bleeding, which is another area that I don't think is generally well cared for. Anemia and why is it important, I think, is the first question. First of all, when I was in training, which is not as recently as I would like to think, but it was back in the 70s, there really wasn't all the excitement about prenatal diagnosis and all the genetics we know today, and ultrasound was barely, was something brand new and barely useful in predicting outcomes for fetuses. And so there was a much bigger emphasis on the things that we could deal with and could manage, and anemia was one of them. I remember in my training that if you allowed a patient to be anemic without attempting to treat it, you were in trouble. So if not with the patient and the healthcare system, certainly with your mentor. So I think what has happened is that there are much sexier things that have come along in women's health and in prenatal care than anemia, and as a result, it's sort of fallen by the wayside. But let me start by talking about the scope of the problem. First of all, anemia has several impacts. It's got an impact on well-being, it's got an impact on health, and it's got an impact on transfusion. This is a study that looked at a survey to show how anemia compares with other significant medical problems in terms of its impact on vitality. And as you can see, start by looking at the second line, which is the hatched line. Iron deficiency anemia before treatment really is equivalent or perhaps even worse in terms of its impact on vitality compared to things like clinical depression, heart failure, chronic kidney disease, cancer. And if you treat it, you can see the top line shows that iron deficiency anemia and its association with vitality goes back to baseline. Look at the bottom line, which is the general population. So there is clearly an impact of anemia on the way people feel. Is there some trick to this? Okay. Then there's an impact on health. If you look at this bar graph, the top line shows the baseline, which is a patient with no heart failure, no chronic kidney disease, and no anemia. And if you look at the impact of anemia on the survival for the next 2 years, you can see that it's virtually, the mortality is virtually doubled over the next 2 years. If you then look at people with kidney disease, heart failure, and then you add to that anemia, in addition to those underlying diseases, you can see that there's a straight line increase in the mortality over the next 2 years. So there's clearly an impact of anemia on health. Now, if I show this slide to the general physician, they would look at it and say, oh, I have an anemic patient with kidney disease, I better transfuse that patient. The problem is there isn't evidence that correcting the anemia with transfusion really does make a difference. It may be something about the underlying disease itself and the anemia associated with it as opposed to the ability to correct the anemia. So I think we all have to bear that in mind. But clearly anemia, the presence of anemia makes things worse. Finally, if you look at the third area I wanted to talk about is anemia and its impact on transfusion. As you know, you saw evidence from Axel a few minutes ago about the impact of starting out a surgical procedure already anemic and increasing the risk of transfusion. And we always thought this was the case, but this study that came out in, I think it was 2006, showed that the same thing does indeed apply to cesarean delivery. In cesarean section, they looked at 23,000 primary cesarean sections, 33,000 repeat cesarean sections, and you can see if the patient's hematocrit was less than 25%, that the chance of needing a transfusion was 17 to 20 times greater than if the patient had a higher hematocrit. And they also showed that for each point of hemoglobin increase, the odds ratio decreased by almost a point. So there's clearly an impact in the association of anemia and transfusion, even in obstetrics. Now, the prevalence of anemia is a real problem. It's about 1 in 4 people around the world, 30% of non-pregnant and 42% of pregnant women around the world. And you say, okay, well, that includes the developing world. Well, look at the United States. Even in the United States, 7% of reproductive age women, 20% of women over 85 have iron deficiency anemia. There's a racial and ethnic disparity so that women who are African American under the age of 50 have about a 25% chance of being iron deficiency anemic. And if you look at pregnant women, there's something between 20 and 40% of them will become anemic during the course of their pregnancy. So why does this happen to women? Well, there are 4 times in a woman's life where there are stresses on the system that predispose a woman to anemia. The first is adolescence, then pregnancy, then perimenopause, and then later in life. So I'd like to talk for a minute about each of these. In adolescence, there's about a 10-fold prevalence of iron deficiency anemia in girls as compared to boys. And there are thought to be 3 main reasons for this. The first is that there's a growth spurt that occurs at the beginning of adolescence. And in girls, this corresponds with the onset of menstruation. And if those 2 things are happening at the same time, there's blood loss and the need to develop, to grow and develop, which requires iron, both competing for the same stores of iron. In addition, many young women who start menstruating start out with periods that are anovulatory periods. And those can frequently be heavier and prolonged and more frequent than normal, regular ovulatory cycles, which will come later. If you then add to that teenagers are very concerned about their body image and what they eat and being thin and probably don't eat as much liver as they need to eat in order to maintain their hemoglobin levels, their iron supplies, you have a problem in adolescence. If you then look at pregnancy, there's a 20 to 30% increase in red cell production that comes with every pregnancy. There's a preferential transfer of iron to the developing fetus who needs the iron for its own growth. And the combination of those 2 things saps the iron stores from the mother. If you add to that the fact that she may be a young woman who was already borderline or anemic or at least iron deficient as an adolescent, or a woman who's had multiple pregnancies close together where she never has a chance to recover her iron stores, you wind up with a setup for the 20 to 40% of iron deficiency anemia in pregnant women. Then there's the perimenopause. The average age of menopause is about 51, and it's been that way since as far back as historic records can indicate. But in the years before menopause, there is often an excess amount of bleeding. 20% of women in that period of time, or at some point in their lives, have excessive menstrual blood loss. About 4% of all visits to doctors' offices for women are related to excessive bleeding. Menses that last more than 7 days or total more than 80 milliliters per cycle, where 35 is about normal, 2/3 of those women will have iron deficiency anemia. The patterns of bleeding can be heavy and regular, or they can be very irregular. They can be associated with fibroids. They can be associated with lack of ovulation in those years before menopause. And in fact, there are many women who walk in the door with fibroids who if you take a careful enough history, you realize they not only have fibroids, but they may not be ovulating at the same time. And so anemia in this group is also extremely common. Now, if you look at the elderly, well, what happens after menopause, since the menstrual blood loss disappears from that period of time, From about 50 to about age 65, the rate of anemia in women decreases. But after 65, it starts to go up again. After 85, about 20% of women are anemic again, and black women are much more likely than non-black women to have this problem. About a third of these anemias are related to dietary issues, nutritional issues. Another third, anemia of chronic disease, also called the anemia of inflammation. And then there's another third that remain unexplained. So I think the first thing we have to do is recognize that you have to identify the anemia, you have to diagnose that it exists, and then you have to figure out what it's from in order to treat it. And really the screening for this is pretty straightforward. There's not one person in this room who couldn't develop a mechanism for doing this simply by asking a history. If you have a history of someone who has heavy bleeding of any kind or has any symptoms that correlate with anemia, you simply do a CBC. If you find that the hematocrit or hemoglobin are low, you can very simply look at the MCV, and if you want to add to that a ferritin level, the vast majority of women who are otherwise healthy, who are menstruating, really don't need much more of a workup than that. So if you have a low ferritin and a low MCV, even a borderline to low normal MCV, it's worth a trial of iron, because iron deficiency anemia is by far and away the greatest cause of anemia in women. If the lab values are not diagnostic, then obviously you need more of a workup. If the lab values are diagnostic and you try the therapy but it doesn't work, then it's also time to refer. So how do you treat iron deficiency anemia? Well, there's the old standby, oral iron. And the data, I'm just kind of giving you summary statements, but there's data for all of this, not only in non-pregnant women, but also in pregnant women. First of all, oral iron works. If a woman takes oral iron on a regular basis and you compare that to parenteral iron, oral iron will get to the same endpoint in maybe a slightly longer time, but pretty close to the same amount of time. So if there's no emergency and the patient is able to tolerate iron, there's nothing wrong with using oral iron. The problem with oral iron is that about 30% of people can't tolerate it, and it leads to stomach irritation, diarrhea, constipation, any GI effect you can imagine. And so because the patient is embarrassed to tell you that she's not taking her iron, you assume that she's taking it. She comes back 3 months later and she's still just as anemic as she was before. So one of the things that I would recommend is that whenever you start someone on oral iron, you tell them right at the outset, some people can't tolerate iron, so I want you to tell me if you can't tolerate it. There's nothing wrong with that. We have alternatives if you can't tolerate oral iron. If iron doesn't work, or if there is some reason that you need to expedite the treatment, or there's some time pressure, then parenteral iron is the way to go. Now, when I first left Englewood, where I was used to using parenteral iron, and went to Beth Israel, I found that I couldn't find even a hematologist who was comfortable giving intravenous iron. And that was because there was this, what my grandmother would call a bubba misa, an old wives' tale, about a 1% incidence of anaphylaxis if you use parenteral iron. And in fact, there are now many, many preparations of parenteral iron. You see some of them here. There are the dextran forms, which are more tightly bound to the iron, and which allows you to give a full dose in one infusion. And then there are the others where the iron is released much more rapidly from its moiety, and as a result, you can't give quite as much. So people have looked at what is the true incidence of life-threatening complications from parenteral iron. And if there's anyone in the audience from the companies that make the dextran irons, they will probably get in a debate over whether these numbers are true. But I think what you can see is that there's nothing in here that's a risk of 1%. We're talking about risks in the 1 per millions, 1 per 100,000 at the worst. The dextrans still require that you use a test dose in order to make sure a patient isn't allergic, but if you're not using a dextran preparation, the other preparations don't even require a test dose. And they're extremely effective, they're very easy to administer, they're very well tolerated, and they're extremely effective. You should see a reticulocytosis after just 3 or 4 days. So one of the things that we like to do, especially if we have someone who's very anemic and you're trying to make a decision over whether to add erythropoietin, we check a reticulocyte count usually within a week, but depending on the severity of the anemia, maybe even sooner. And you should start to see reticulocytosis within just a few days. You should also see a rise in hemoglobin by about the 7th day, and you should expect a rise of about a gram a week. If someone is severely anemic and has good levels of erythropoietin, endogenous or exogenous, you can see that rise even faster. So another myth that exists out in the community is that it takes too long to raise the hemoglobin level by giving parenteral iron, and therefore we need to transfuse the patient. Well, it's not true. I think the experience here in Englewood, and I can tell you our own experience with patients who cannot accept transfusion, who are severely anemic, is that if you reduce their metabolic needs, you tell them to rest, you have them not get out of bed to go to the bathroom, you'll find that in a very short time they are capable of doing all of those functions simply by giving them the right aggressive amounts of iron and, if necessary, erythropoietic agents. The second area that I'd like to talk about, again, specific or at least prevalent in women, is obstetric hemorrhage. Obstetric hemorrhage is a very serious entity. It is the #1 cause of maternal mortality in the United States. And in fact, New York State has the honor of being among the highest rates of maternal mortality based on obstetrical hemorrhage. Obstetric hemorrhage accounts for 25% of all the pregnancy-related deaths worldwide, which means it's several 100,000 a year. The uterine atony, or the failure of the uterus to contract adequately after delivery, is the #1 cause. But lacerations of the cervix or the vagina or the uterus, retained tissue inside the uterus that prevent the uterus from contracting adequately, coagulopathy, either pre-existing or coagulopathy that develops in the course of the pregnancy or the delivery, and abnormal placentation, things like placenta previa, placenta accreta, which is on the rise since the cesarean section rate has gone up. All of those things are known causes of obstetric hemorrhage. Nature has developed some compensatory mechanisms in anticipation of the blood loss that's expected at the time of delivery. As I mentioned earlier, there's a 25% increase in the red blood cell mass. There's a 40% increase in intravascular volume. And all of that is thought to be in preparation for the known blood loss that's going to happen at the time of delivery, so that you're not losing your baseline red cells and volume, you're losing the additional that was available to you during the pregnancy. In addition to that, physiologic changes that occur are related to coagulation. There's a decreased platelet count, there's an increased von Willebrand factor, and as you can see, other factors. There's an increase in fibrinogen, antithrombin 3, protein C. There's a decrease in inhibitors of coagulation, such as protein S. There's a decrease in fibrinolytic activity, as you can see. And all of these things lead to a net hypercoagulable and hypofibrinolytic state, which overall increases the clotting and the persistence of clot, and therefore limits the blood loss at the time of delivery. On the negative side, all of these increases in coagulation and decrease in clot lysis also increase the risk for thromboembolic phenomena, usually for about a month after delivery. There are common coagulation tests that we frequently use, but the reality is that none of them can detect the hypercoagulable state or the lack of such a hypercoagulable state in pregnancy. What I'd like to talk about for the next few minutes is the new developments in the management of obstetrical hemorrhage that have come about, and you can imagine the reason for that, because the old methods are not as good as we'd like them to be. The first thing is something that you've heard about several times this morning. Dr. Friedman showed his horse with several saddles on it. You heard from several people about the multidisciplinary approach to minimizing the need for transfusion, which includes stopping the bleeding, correcting coagulopathy, correcting anemia, all of those things. And the major bodies that are involved in obstetric care have also said the same thing. One of them in the United States is the American College of Obstetricians and Gynecologists, who in 2006 formally made the statement that an organized, comprehensive approach to the care of postpartum hemorrhage benefits the patient and reduces mortality and morbidity. There are three components to the approach, as you well know, those of you who are interested in patient blood management are well aware. One is to control the bleeding, then to maintain blood volume and tissue oxygen delivery, and prevent and treat coagulopathy. I'm going to spend most of the next few minutes talking about the issues related to the coagulopathy and not so much about the specifics, the obstetrical approach to treating bleeding. The traditional approach to dealing with postpartum hemorrhage or peri-obstetric hemorrhage is to provide products based on clotting status and clinical bleeding status. So FPP, platelets, cryoprecipitate have been used. They're given periodically based on how many red cell units have been given, really empirically, and the state of clinical bleeding and the clotting status. These decisions are often based on things like ProTime, INR, PTT, fibrinogen levels, platelet counts, but the reality is that none of these tests really is specific to tell you what is missing, what is not functioning properly. None of them is available fast enough to make a difference, so that by the time you get the ProTime result, you've gone so far, even if the ProTime was normal when you drew it, it may no longer be normal. And again, these values do not tell you anything about what component of coagulation is missing or needs to be replenished. The traditional approach also may have negative impact. Traditional resuscitation may, in fact, worsen coagulopathy or even cause coagulopathy. Some of it has to do with the fact that you're diluting factors and platelets. Some of it is the ongoing hemorrhage because you haven't stopped the bleeding fast enough, is consuming factors and platelets, and therefore you're using them up. Hypothermia and acidosis, which are common sequelae to postpartum hemorrhage, can make things worse. And the massive fluid resuscitation can also make things worse, in part by increasing intravascular hydrostatic pressure and taking the newly formed clot that's on the end of that blood vessel and pushing it off because of that increased pressure. And as a result of this, people are starting to think about new approaches to deal with this coagulopathy and the resuscitation efforts. These are the four that I want to talk about each briefly. First of all, there's hemostatic resuscitation. Secondly, early administration of fibrinogen, tranexamic acid, which you heard a little bit about earlier. Of course, I have the opportunity to talk about it in obstetrics, only because you guys are all afraid of women, especially pregnant women. Thromboelastography and thromboelastometry are tests that I would like to talk about briefly as well, as in terms of how they might apply to directing therapy in these conditions. So hemostatic resuscitation is something that's relatively new. It's been very widely adapted, even though there is really a dearth of evidence to show that it's the right thing to do. And what that primarily it relates to three components. The three components are to limit the amount of crystalloid in order to prevent hemodilution and to keep blood pressure a little bit on the low side in order to prevent that hydrostatic pressure from disrupting clots. And so it's recommended to keep blood pressure at 80 to 100 systolic. In other words, don't try to restore it back to normal levels. The second is the earlier use of platelets and fresh frozen plasma in that 1-to-1-to-1 ratio that you've all heard about. Now, all of this is based on military data, retrospective, that show a decreased mortality for soldiers who were given this 1-to-1-to-1 ratio, primarily the fresh frozen plasma, in addition to red cell transfusion. But upon closer scrutiny, it appears that there was a significant survival bias in these studies. It takes a while, it takes close to an hour to thaw the fresh frozen plasma. So if you had a soldier who was injured and who was so sick and so traumatized that he didn't survive an hour, that individual wound up in the non-fresh frozen, non-plasma group and wound up being counted as a statistic and as a mortality in the group that didn't receive plasma. Those who survived longer were the ones who got the plasma, and it may have to do with the fact that their injuries weren't as severe as those who did not live long enough to get the plasma. And in fact, if you take that, if you exclude the early deaths, the data does not really show a survival benefit for that 1-to-1-to-1 ratio. The third thing I'd like to talk about just briefly is the off-label use of recombinant factor VII. Now, the mechanism of action in these settings is that recombinant factor VII will bind to exposed tissue factor at the site of injury. It'll activate the coagulation cascade, and that will lead to local fibrin deposition and essentially clot, and the bleeding will stop. The problem is that it also binds to activated platelets, leading to fibrin deposition distant from the site of injury, and it's been associated with thromboembolic phenomena, primarily arterial thrombi. So there is concern about the risk-benefit ratio with this medication. It's most effective after you've gotten control of major bleeding, that is the major bleeding source. So if you tied off the big arteries and veins and you're still oozing and bleeding, then that would be the time to try the recombinant factor VII. Ideally, you should have a platelet count that's above 50,000 and high enough fibrinogen levels. The patient shouldn't be too cold and shouldn't be too acidotic and should have a normal serum calcium. So it sounds like you got a lot to do while you're deciding to give the recombinant factor VII. And there are studies in the literature. There are 17 randomized trials that show reduced transfusion requirements, but no mortality benefit from this agent. In obstetrics, there are many case reports, and there are anecdotal stories of how the drug was used successfully, but there are no controlled trials to really evaluate it. Now, the early use of fibrinogen is, to me, one of the most exciting things on the horizon, assuming it pans out. And this derives from a study that looked at 128 women with postpartum hemorrhage. This was published in 2006, and what they found was, of all the parameters that were measured at the time that postpartum hemorrhage was diagnosed, the only one that predicted the severity of the hemorrhage was the fibrinogen level. So for each gram decrease in fibrinogen, each gram per liter decrease, they found there was a greater than 2.5-fold increased risk of severe hemorrhage. And if the fibrinogen level was less than 2 grams per liter, there was a 100% occurrence of severe hemorrhage. And using this information, people have taken it a step further. I will talk about that in a second, but let's talk a little bit about normal pregnancy and fibrinogen levels. In pregnant women at term, fibrinogen levels range between 3.5 and 6 grams per liter, which is significantly higher. If you look a little further down under why fresh frozen plasma is not the best source, fresh frozen plasma, which does not come from pregnant women, contains 1.6 to 3.5 grams per liter. And if you look at the second point here, OB hemorrhage is associated with fibrinogen levels of 1.5 to 4. So you can see that what you give back in fresh frozen plasma is really no greater than the level at which you may be starting to see hemorrhage. So that using fresh frozen plasma may not be the best agent in order to replenish stores of fibrinogen. In addition, the current guidelines suggest you start replacing fibrinogen when the level of fibrinogen is less than or equal to 1 gram per liter. And if you remember the last slide, 100% predictive of severe hemorrhage was a level of 2 grams per liter. So the recommendation now really should be modified so that 2 grams should be a cutoff for consideration of giving fibrinogen. Again, remember that I'm saying that based on these numbers, but there really isn't significant evidence yet that this is really the right way to go. Fresh frozen plasma, as I said, may not be the best source, and in fact, the fact that the amount of fibrinogen in fresh frozen plasma may in fact be less than the patient already has, you may be further diluting her fibrinogen level as opposed to helping her. So what is currently available in the United States that might be a better source of fibrinogen would be cryoprecipitate. But of course, cryoprecipitate, you're talking about the risk of pooled cryoprecipitate, so exposure to more than one donor. Now, does fibrinogen really make a difference? Well, there are six cases reported of OB hemorrhage and measured early low levels of fibrinogen. Fibrinogen concentrate, which is available in Europe, was used to correct the low fibrinogen levels. And in these 6 cases, the laboratory studies were corrected to normal and bleeding was stabilized. The combination of all of these little bits of information, that is the value of looking at a low fibrinogen level plus the suggestion that fibrinogen concentrate may be effective in reducing the severity and the duration of hemorrhage, have led to the thought that this is something that really needs to be studied and see whether there really is potential for it. The other agent that's been looked at now and people are starting to talk about in obstetrics is tranexamic acid. As you've heard earlier, and as I showed you a few minutes ago, tranexamic acid is a potent inhibitor of fibrinolysis. Therefore, because OB hemorrhage is associated with increased fibrinolysis, there may be benefit in giving tranexamic acid in order to prevent that early lysis of the clot. It is, as you heard from Dr. Gross, it's been shown to reduce blood loss in many areas of medicine. It's been shown to shorten the duration of bleeding, and in obstetrics, it's been shown to reduce the rate of progression to severe hemorrhage in patients who have postpartum hemorrhage. Other studies, which are small studies, but they've shown that you can reduce, even a patient who's not hemorrhaging, you can reduce the volume of blood loss at vaginal and at cesarean delivery through the use of tranexamic acid, essentially prophylactically. And again, we need to define the dose, the cost, and how to use it, but there is really significant potential here, at least theoretically. And then lastly, as relates to obstetric hemorrhage, another area that is not really new, but it's an area that I think needs wider application in dealing with acute hemorrhage, is the use of more efficient, more valuable testing, point-of-care testing, to assess coagulation and coagulopathy and to specifically direct treatment. Thromboelastography has been around since the 1940s. A modification of that, thromboelastometry, is now also available. Both of them measure the viscoelastic properties of clotting blood as clot develops and then as clot lyses. They're both performed on whole blood, which means you don't have to waste the time involved in separating cells from plasma. You get a quick answer, and you're not separating out the factors from the cells, all of which may have to work together in order to form clot. So it's an opportunity to look at the entire process of clotting rather than counting platelets and looking at individual areas. As clot forms, this device moves through the clot, and the motion change is converted to a graph, and the idea is you make your diagnosis based on what the graph looks like. The components, the various parts of the graph represents different parts of the clotting process. The maximum amplitude represents platelet function. The early portion is really a close approximator of fibrinogen levels, and then clot lysis is reflected by the late part of the test. This is just an example of what the graph looks like, and that early part represents the availability of clotting factors. The peak represents the functioning of platelets, and then fibrinolysis at the end. So this new knowledge and new therapies and new diagnostic testing methods for coagulopathy are hopeful additions to our armamentarium, which we hope may change our approach to the treatment of patients with postpartum hemorrhage. We do need more studies to define, first of all, what is normal in pregnancy, what is not normal in pregnancy. They may not be the same as in the non-pregnant state, and we need to refine these approaches and better define risks and benefits and therapeutic regimens to apply to this problem. All right, the third area that I want to address is the area of perimenopausal bleeding, which is not generally as acute as obstetrical hemorrhage, but can often be very severe and very debilitating, and in fact can progress to the point of being life-threatening. So as I said earlier, about 20% of women suffer from excessive menstrual bleeding. 40 out of every 1,000 visits to the doctor are related to abnormal uterine bleeding. It's a common cause of perimenopausal anemia. Short menstrual cycles and irregular bleeding, heavy bleeding, prolonged flow at the time of a menstrual period, all are patterns that can be associated with this problem. The most common causes are anovulation or fibroids, or a combination of the two, but there are other entities such as a condition called adenomyosis, which is also highly associated with heavy or abnormal bleeding. And then there is a significant portion of women in whom we don't know why they're bleeding. But all of this leads to about 200,000 hysterectomies a year in the United States done for abnormal bleeding. And if you kind of think about the whole picture, here's someone who has abnormal bleeding, is probably anemic, and as a result of that needs to have a hysterectomy. Now you've taken someone and you've set this individual up by not correcting those problems prior to hysterectomy for the possible risk of a transfusion and the morbidities related to either the severe anemia at the time of surgery and or the chance of transfusion. So we talked a little bit a few minutes ago about the definition of menorrhagia. It's interesting that the academic bodies that define these words are now starting to talk about uterine bleeding in different ways. They're talking about them as relates to the etiology of the bleeding instead of calling them menorrhagia and metrorrhagia. But whatever you call it, it's heavy, excessive vaginal bleeding. The definition of periods that are too heavy or too long are periods that last more than 7 days or yield more than an 80 milliliter per month blood loss. Up to 2/3 of women, as I said earlier, who have that much bleeding will wind up with iron deficiency anemia. There are a lot of ways to stop the bleeding. You can use hormonal treatments, combination contraceptives, meaning oral contraceptives or contraceptive patch, or something called the NuVa ring, which is a delivery system. That's a ring that goes into the vagina and slowly releases the same hormone medications that are used in birth control pills. All of those can be very effective in reducing the blood flow at the time of a menstrual period. One of the things that's probably underutilized but has been studied and is probably the most effective method of reducing perimenopausal bleeding is the levonorgestrel IUD. The brand name of that is the Mirena IUD. So in our place we have family planning experts who, after you hear them talk about it, every man in the room will want one of them. But they are extremely good devices, and they really have been shown to be very effective in reducing bleeding, blood loss, and patient satisfaction in terms of menstrual cycles. There are injectable gonadotropins that can be used to stop menstrual cycles, and all of these things have their use. But again, going back to the concept of a multimodal approach to treating these women, one of the things we see frequently is a woman comes into the emergency room with a complaint of heavy vaginal bleeding. Someone checks her hemoglobin, it's 5, and they say you need a transfusion, and they either get talked out of doing a transfusion or they give her a transfusion and they send her home, but no one has addressed the underlying problem, the bleeding. That bleeding may have stopped an hour ago, and so she's not bleeding when they see her. And even if they treat the acute bleeding, they don't always remember that this is something that's going to happen again next month if you don't deal with it now in a prophylactic way. So there are surgical approaches as well, depending on the patient's needs and her individual situation. You can do a myomectomy. You can remove a fibroid from inside the cavity of the uterus without ever having to make an incision. If you do it transcervically, you can remove the entire uterus through a whole bunch of different low-tech and high-tech methods, some of which are associated with greater blood loss, some with less. But all of these surgical approaches are certainly available, and most of them are very traditional. But the one thing that should be the common denominator is the approach to surgery should be a blood conservation approach to surgery. You want to control the major and the minor bleeding, meticulous and continual hemostasis. For instance, I remember when I was in training, I think it was my first myomectomy, I assisted someone, and what he had us do is make multiple incisions in the uterus, take out all the fibroids without sewing up any of the incisions. So now there were 4 incisions bleeding instead of 1, and stop the bleeding from that one and go on to the second one. So things like that really are very important, and if you weren't trained to think that way, you need to start to think that way. Gentle handling of tissue using cautery, bipolar, harmonic scalpel. There are all kinds of devices now that reduce blood loss. Using minimally invasive techniques has been shown to reduce blood loss compared to the major open techniques. There are all kinds of things that really are rapidly becoming standard. And then if you add to that intraoperative cell salvage and reinfusion, you really are doing a lot to minimize the potential for transfusion. My thumb's getting tired. And then there are some very specialized procedures for uterine bleeding that I'm sure all of you in your institutions have started to experience. There are newer things like uterine artery embolization. So we all know about the benefit of uterine artery embolization for fibroids, but if you cut down the blood flow to the uterus, it's good for any kind of uterine bleeding. So if you have, and we use this pretty commonly for someone who can't accept a transfusion, who's been bleeding, again, you don't want to waste a lot of time with someone who can't accept a transfusion. So you don't have time to try 3 different courses of 3 different kinds of hormonal therapy. You may want to try 1 dose. If it doesn't work, you need to do something more aggressive, and uterine artery embolization is one of them. It works extremely well in that acute situation. It's relatively contraindicated for a woman who wants to have more children, and that's not because it's been shown to have a negative impact, but it's only because we don't know what the impact is. So there are many anecdotal case reports of women who've had embolization who go on to have a normal pregnancy, and we don't know that there is any negative impact on the ability to conceive or the ability to carry a pregnancy or on the complication rate related to a previous previous embolization procedure. And then you have the traditional D&C, which is something else that's underutilized these days. The use of progesterone to cause what is referred to as a medical curettage has really overtaken the old tradition of doing a traditional D&C. Now, traditional D&C does not solve the problem long term, but it is a very effective way of stopping bleeding acutely. So someone is having a heavy period, you can't stop it very quickly in some other way. A quick D&C usually will do the trick. And then if you add to that, if necessary, balloon tamponade, where you put a big Foley balloon into the uterus and you inflate it and compress and allow the blood as it fills up the uterus to then compress the walls of the uterus, those are all very effective, very simple, low-tech techniques that have been shown to stop bleeding very effectively. So this is just kind of a summary of that. What you have to do, again, one of the things I like about patient blood management professionally for me as a clinician is the ability to be creative. If you think about a situation and you just apply all of these things that you may have learned in other situations and really customize the treatment for the individual, I find it a very exciting thing to be able to control bleeding, to be able to treat a patient who everyone else in the room would have transfused or done something much more radical. And I think if you're willing to look for and accept that challenge, it's really a very rewarding thing to do. If I could make this is rewarding too. All right, so in summary, these are the 3 areas. This is, I consider, a sort of a potpourri of what these 3 areas really have in common is that they are all women's health issues and that they touch upon the issue of patient blood management. And I think there are new exciting developments in all of them, and then there are some old-fashioned approaches that we need to rediscover. And I think there is tremendous opportunity to improve safety, reduce transfusion, and improve quality of life and health if we address all of these things in women. And with that, any questions? Thank you.